diabetes, dyslipidemia, or hypertension. So how would you risk stratify this patient? So he falls in the high risk category. These are the patients who have markedly elevated single risk factor, such as total cholesterol, LDL, or a BP more than 180. These are the patients with family history but without other major risk factor, like in our patient with diabetes mellitus but without target organ damage, a patient with moderate CKD, and a score level of more than 5 but less than 10% for 10-year risk of fatal CVD. So how must these patients be managed? Again, I have a bit simplified this criteria. So if the initial LDL is less than 70, the only thing to be done is lifestyle modification. If the initial LDL is 70 to 100, lifestyle followed by drugs, and an LDL more than 100 entails lifestyle plus upfront drug therapy. So this is the last two categories of ESC guidelines. This is the moderate risk categories, which include patients, young patients with diabetes mellitus of less than 10-year duration, and calculated risk score of 1 to 5%. For these patients, upfront therapy with the lifestyle intervention and drugs are started at the level of 190. Similarly, this is the low risk category. Patients included are those who have a score level of less than 1%. And for them as well, the treatment is started with drugs if the level of LDL is more than 190. And between 116 and 190, lifestyle modification are first tried, followed by the drugs. So these were the risk stratification used in the ESA system. Now I'll briefly discuss the classical 4 statin groups of the AHA guidelines, which included patient with clinical coronary or cerebrovascular disease, patient with diabetes and age above 40, patient with atherosclerotic disease risk factor of more than 20 or between 7.5 to 20% with risk enhancing factors, and patient with dyslipidemia, that is LDL cholesterol more than 190. So as per the ACC guidelines, these 4 groups are the main candidates for statin therapy. So I will jump back to my first scenario. So for who had anterior wall MI and he was managed with primary PCI to LAD. Now he was started on statin, but what will be his target LDL? So as per this guideline, the target was reduced from 70 milligram per DL, which were used in the AHA guidelines, and the new target was set, which was an LDL level of less than 55, and an additional criteria was added that LDL must be reduced more than 50% from the baseline. So this is for the very high risk patient or the patient who have had a clinical event. Then another category was added, but this was class 2B. These were for the patient who had a second event within 2 years. For them, 50% reduction was coupled with a target LDL level of less than 40. So this was some change in the guideline. A new criteria of LDL of 55 was set for most of the patient and 40% for very high risk patients who have had recurrent events. So coming back to the patient, now patient was started on rosuvastatin. Lipid profile was repeated after 4 to 6 weeks and it showed an LDL level of 60. So because its starting level was 65, so our target is for this patient must be below 55 and we also haven't achieved 50% reduction. So what to do now? This is how to modify the treatment strategies when the targets are not met. So the first treatment is always high potential statin, like the rosuvastatin 20 milligram given in this patient. If the LDL goal is not reached, then second line drug is the azetamib. And if still goals are not reached, then we have to add PCSK9 inhibitors. So these are the 3 treatment strategies which can be used for lowering LDL in most.
I think that Dr. Ali's screen has frozen. I think we'll wait for him to come back. I'll contact him and ensure that he's back online as soon as possible.
I think he started the lecture on a very nice note, and it was an excellent start. I'm sure he's going to build it up, perhaps some internet problems or something like that. But I think we should not lose the audience. They should still stick to it. Vyavastha hai shajar se umeede bahar rakh. So is he
Very right.
responding?
Thanks, sir.
Good to see you, Hamza. Good to see you. Huh?
I think, sir, let's continue with that scenario since you injected your thought in. So I think baseline LDL was 65. So personally, I believe in 20 milligram of rosuvastatin would be enough to bring target to less than 55.
Sure.
Yeah.
Yeah,
But
I think this is perfect.
Let's assume this scenario to be LDL of 100. So how to go about?
Yeah, I think in case of even 100, you start with rosuvastatin 20, and then you wait and you see that you have to bring it down to 55. And if it does not come down, then you have to add ezetimibe. The new kid on the block that he did not mention was bempedoic acid. Again, that is something before we even consider PCSK9, which is not available, atrociously expensive. This is something that we should think about before we go even think about PCSK9. So ezetimibe will be considered on testing when it happens.
But I'm making it more towards starting right from the beginning combination. Let's see, the baseline LDL is 130.
You're taking it up a notch every time.
Yeah,
that's
so
right. He's trying to lay
and few
more
studies
difficult
have
pitch.
really made this that you can start combination right from the beginning if you think that you're going to have your target with maximum statin therapy, because initial phase is also very important post-event period to get your, it's not just to getting the target, it's getting the target as early as possible as well. So that I just want to inject this thought as well, that a number of time we just start and wait and then wait and then wait, so we can at least ezetimibe.
Very right.
I think he's
Assalamu
back.
alaikum, guys. How are you? Very interesting discussion. मैं वीडियो इसलिए ऑन नहीं कर रहा कि नेट का प्रॉब्लम होगा. You know, it's not a bad idea to start all of these guys with a combination. क्योंकि उससे side effect भी कम होंगे. You'll get a much higher response to a lower dose of statin. And देखिए, till now, bempedoic acid is only added if there's side effects which are intolerable, or you don't get the desired level, and before you go to PCSK9. ऐसे ही है ना सर?
Sir,
बिल्कुल ठीक फरमा रहे हैं आप.
बिल्कुल sir,
Sir,
there are
आपने
two
कुछ गलत फरमाया आज
recommendations.
तक.
Very right, sir. Very right. There are two recommendations for bempedoic acid. I mean, it's a class 1 if they're intolerant to statins, and if they can tolerate statins, then it becomes a class 2 a recommendation. So ezetimibe is a class 1 as a combination. That's very
I
right.
think it's a fascinating discussion, but I think we should get Dr. Ali back to finish his talk, and then we'll get into the meat of it. Thank you.